Hello everyone. Today we will discuss about enuresis in children. So we will discuss in this video what is enuresis and how bedwetting is a very common problem in pediatrics and whether it constitutes actually a disease or a normal development phenomenon, and what are all the age limits beyond which it cannot be tolerated, and what are all the pharmacological as well as non-pharmacological methods. So this is such a useful topic, not just for exam point of view but also from a practical point of view. You will always encounter anxious parents complaining about bedwetting habit amongst their children. So this is useful and handy for you to have this information. Enuresis is involuntary passage of urine beyond the age of expected bladder control, that is greater than or equal to 5 years. When it occurs at least twice a week for 3 months and not due to any structural or neurological disease. So remember, the age of the child should be greater than or equal to 5 years, and it has to happen at least twice a week for 3 months and not due to a structural or neurological disease, commonly known as bedwetting. So what is normal bladder control and how it is developed? So as far as a newborn is concerned, voiding is a pure reflex. Bladder empties automatically whenever it is filled, and no cortical control. Urination is involuntary. Child becomes aware of bladder fullness but cannot yet control to urge the void. Awareness begins but voluntarily absent. So, in the age group of 2 to 3 years, voluntary control during the day starts as cortical inhibition over bladder reflex matures. Toilet training can be initiated in this age. In the age group of 3 to 4 years, there will be daytime incontinence achieved in most children, and majority attain stable daytime control. And 4 to 5 years, nighttime control is usually established. Persistent bedwetting after this age is abnormal. After 5 years, physiological and psychological readiness for complete bladder control is expected. Enuresis is diagnosed only beyond this age. Classification. So one is nocturnal enuresis, where there is bedwetting during only sleep, which is most common. Then diurnal enuresis, where there can be daytime wetting, and combined, where it can happen both at day and night. Primary and secondary. So primary is never dry for greater than or equal to 6 months, whereas in case of secondary, recurrence after 6 months of dryness is achieved. 15 to 20% of 5-year-old and 5% of 10-year-old and 1% of adolescents experience this habit, and it is more common in boys. Familial tendency, wherein there are up to 70% if both parents were affected. The etiology, organic causes, urinary tract infection, congenital anomalies, neurogenic bladder, diabetes mellitus or insipidus, constipation or sleep disorders. Functional or psychogenic causes, delayed bladder maturation, low ADH secretion at night, and deep sleep and emotional stress and genetic factors. Enuresis occur when there is a mismatch between bladder capacity, that is often small, or nighttime urine production is often high, and ability to wake up in response to a full bladder is not present. This leads to involuntary urination during sleep. Clinical evaluation. First, you have to ask a thorough history regarding frequency, timing, and stress factor, and examination of abdomen, spine, genitals, and neurology. So, the investigations include UTI, blood sugar, and ultrasound KB to rule out any anatomical causes. So, the diagnostic criteria include repeated voiding of urine into bed or clothes, involuntarily or unintentionally, occurs at least twice a week for 3 consecutive months, or causing significant distress or impairment. Chronological or developmental age is 5 years or older. The behavior is not due to medical condition like diabetes, epilepsy, or anatomical abnormality. So this is when we classify this as enuresis. Differential diagnosis include urine analysis and culture for ruling out UTI, blood sugar test for ruling out diabetes, urine specific gravity and osmolality for diabetes insipidus or psychogenic polydipsia, renal function test to evaluate renal parameter, ultrasound KB, and with a post-void residual to identify structural anomalies or incomplete bladder emptying. Then voiding cystourethrogram indicated in recurrent UTI and suspected vesicourethral reflex. MRI spine if neurological causes suspect. Management, plain reassurance to the parents, which is often self-limiting and common, is sufficient, followed by behavioral therapy of fluid restriction and voiding before night, with motivational therapy with reward charts as well as positive reinforcement. Then enuresis alarm, wherein effective long-term conditioning tool. So used only in older resistant cases with desmopressin, synthetic ADH, 0.2 to zero point 0.4 milligram per day at bedtime. Imipramine increases bladder capacity, reduces REM sleep, using it cautiously. Oxybutynin for detrus or instability or daytime urgency. Remember, this is always used in older or resistant cases. So, treat the underlying causes like antibiotics for UTI, bowel regulation for constipation, management of diabetes or neurological causes, and counseling for emotional stress in secondary enuresis. Prognosis is excellent. Most children achieve dryness by adolescence. Annual spontaneous resolution is 10 to 15%, and persistent cases only need specialist evaluation. So, to summarize, bladder control usually develops by 4 to 5 years. Enuresis after this stage is also benign and self-limiting. Behavioral training and reassurance are the first time measures. With patience and support, almost all children achieve continence. I hope you have learned through this presentation. Thank you for watching.